Thank you, Linda. Let me get rid of some of the papers. That's all right. While I'm doing that, let me just say that I have a bit of a froggy throat, and that's a consequence of spending yesterday cheering on my granddaughter's soccer team. So, thank you for the opportunity to speak with you today. It is always a pleasure to talk about healthcare. I've been fortunate to have a career that has allowed me to live inside the healthcare world and personally witness both the administration of healthcare services and how science and medicine intersect in the care of patients. Now you know that I began my Mount Sinai career as the administrative director of the hospital's solid organ transplant programs. One of the requirements for me to secure this position was to go inside the OR with the surgical team and observe a liver transplant. This experience only solidified my passion for the field. How healthcare has changed is an exhaustive topic, and that is because there are so many things going on in healthcare today. I often compare healthcare to a Class 5 rapid. Every day, reading healthcare journals and publications that help keep me current with many of the changes rapidly unfolding. One of my administrative physician colleagues recently told me that he's giving up trying to follow all the changes. Instead of all that swirl, he focuses on teaching human anatomy to medical students. His comment was that no matter what is going on in healthcare, the location of the heart, the location of the lungs, and the location of the kidneys never change. I am, on the other hand, constantly excited about the changes. So I've selected a few to highlight in this talk to all of you today. The first one that I know you can relate to is how our own experience with healthcare has changed over the years. I grew up, like many of you, without a phone that contained my medical record. I made an appointment to see a physician using a desk phone. And when I needed a follow-up appointment, the office assistant took out a big calendar and penciled me in, always in pencil in case there were changes. Today, we have patient portals, electronic medical records, and phone apps to manage our health. In certain medical practices that I work with, we actually prescribe apps based on diagnosis. My Sugar and Glucose Buddy are two apps that are prescribed for newly diagnosed diabetics. Our electronic medical records travel with us, and we are in charge of it. It is no longer the exclusive domain of the physician. When we have a question about the content of our medical record or need a referral for specialty care, we can put a question in the portal and in most cases get a reasonably prompt answer. I recently went for a hearing test and forgot to bring the required prescription. I went on my phone, accessed the portal through facial recognition, and requested the prescription and received it in less than 30 minutes. So this is all a big paradigm shift. In the past, after I completed a medical visit, I never got a survey to see if I was satisfied. In fact, there was no focus on satisfaction or happiness. And why was that? Because in those days, there was no reimbursement for patients being happy. Today, a component of healthcare reimbursement, both to doctors' offices and hospitals, is based on satisfaction scores. This is why hospitals now often look a bit more like hotels, and physicians often try to make some type of personal connection at each and every visit. Another change in the healthcare landscape is the formation of large healthcare systems. In years gone by, we identified with an individual physician or an individual hospital or medical facility. We never heard of health systems. Each hospital was independent on its own and competed with the other hospitals in the area. Working together was not the norm. And perhaps we can hearken back to the underlying competition question. Does Macy's tell Gimbel's? The formation of healthcare systems began to accelerate in the late 1980s and early 1990s. These systems emerged for a variety of reasons, not the least of which is tied to the business concept of market power, where hospitals merge across markets to increase their bargaining position with insurers that are anxious to have strong provider networks for the purposes of attracting employers with large numbers of employees. Should you want a scholarly reference to understand market power and other forces that brought hospitals together, I recommend reading Michael Porter's work on the 5 competitive forces that shape strategy. Healthcare systems have also helped hospitals to achieve enormous cost savings in functional areas such as finance, human resources, the acquisition of medical equipment, including the electronic medical record that we just spoke about. The initial purchase of an electronic medical record represents one of the single largest capital expenses that health systems make, and the cost to update and maintain these systems is an annual cost in perpetuity. Today, in 2023, healthcare systems dominate the marketplace. In fact, these systems hope that you, the consumer, will identify yourself not just as a patient of a particular physician, but rather as a Northwell patient, or a Catholic Health patient, or a Mount Sinai Health System patient. Healthcare systems are large in scale and scope and hope to take care of you and your family from birth through old age. There are also forces at work that have turned these systems into focusing not only on individual health, but also public health and the common good. The difference between medical care and public health is that medical care concerns itself with the individual patient, while public health is about protecting the health of all people and the communities they live in. This work is achieved by promoting healthy lifestyles, engaging communities in health promotion, researching disease and injury prevention, and detecting and responding to infectious diseases. This shift to a public health focus, in part, to no one's surprise, is also reimbursement-driven. Payers are rewarding hospitals and physician practices for population health. Simply put, population health refers to the health status and health outcomes within a group of people, rather than considering the health of one person at a time. Medicare, for example, looks at its members attributed to a healthcare organization and will provide additional reimbursement for how well their diabetic population is managed, or efforts made to prevent heart attack and stroke. The focus on population health requires providers to improve all patient outcomes and invest in the communities they serve. In fact, healthcare literature tells us that the care delivered within the walls of a hospital or outpatient practice impacts as little as 10% of an individual's long-term health. The conditions in which individuals are born, grow, work, live, and age make up the remaining 90%. And to truly serve their communities, health systems must recognize what we now refer to as the social determinants of health. The categories of social determinants of health include economic stability, the neighborhood where people reside, education, food, the availability of social and community support, and of course, access to health care. What difference do the social determinants of health make? Well, some of you may remember that in a talk I gave on the Affordable Care Act, I referenced that life expectancy here in Garden City is 84 years of age, and in nearby Hempstead, life expectancy is 79 years of age. We tie this difference back to specific social determinants of health. In fact, the CDC measures community performance on social determinants of health through what is known as the Social Vulnerability Index. A common clinical practice example of the role of social determinants of health is the patient with long-term chronic headaches that have been unresponsive to a variety of pharmaceutical interventions. When a physician trained on the social determinants of health encounters that patient with chronic headaches that have not abated with medicine, he will ask this question: tell me about your home. So let's look at some of the ways health systems are addressing these social determinants of health, and in so doing are taking responsibility for healthcare in ways that we could never have imagined. The 11 hospital system, Health and Hospitals in New York City, has started a program known as Guns Down, Life Up. This program partners with public health professionals and community-based organizations to prevent and interrupt the cycle of violence that robs youth of their full potential. Northwell Health, through its Office of Community Health Investment, operates a food as medicine program. The program identifies patients who are food insecure and provides a 3-day supply of food and connects them to federal programs such as the Supplemental Nutrition Assistance Program, or SNAP. The Montefiore Health System has a housing at risk program to connect their patients to housing resources. It is driven by an alert system that identifies housing insecure patients upon intake. They have partnered with a community-based organization to offer respite housing when permanent housing is more difficult to secure. The Mount Sinai Health System operates, also in partnership with a community-based organization, a program that proactively identifies and provides free legal services to patients in underserved communities who have unaddressed legal needs that impact their health outcomes. And here is one of my personal favorites. The Community Health Network in Indiana established an on-site farm on one of its hospital campuses to help families in Indiana gain access to nutritious foods. The health system has 3 acres of land and employs a dedicated farmer to grow and harvest fresh produce. Kaiser Permanente Healthcare System in California recently announced a partnership in the Bay Area, creating affordable housing options for improving patients' health. This health system is investing over $50 million in local housing projects. This focus on social determinants of health now is beginning to have deep roots. In medicine, the Bible for diagnoses is the International Classification for Diseases, or ICD. It is embedded in every clinical and billing operation nationwide. Now, the ICD contains unique codes for the social determinants of health. While these codes are not yet tied to a specific reimbursement schedule, they are meant to indicate those factors that are contributing to the patient's condition. Here are the titles of the 5 codes as they exist today. Problems related to education and literacy, problems related to employment and unemployment, occupational exposure to risk factors, problems related to the physical environment, and problems related to housing and economic circumstances. The Center for Medicare and Medicaid Services establishes all of the billing rules that must be followed by Medicare and Medicaid, as well as commercial payers. This year, the assessment of social determinants of health is voluntary. Next year, in 2024, it will be required of all healthcare providers submitting claims for reimbursement. All of this is a seismic shift in healthcare and how it is orchestrated. I appreciate this shift because it appeals to me as an ethical humanist, a public health professional, and for its focus on the common good. It is also the way we might finally improve our population health metrics. This is vital, since as many of you may know, our nation spends the most on healthcare when compared to other high-income countries across the world, and yet many of our outcomes are the lowest. For example, we have the lowest life expectancy at birth, the highest death rates for available or treatable conditions, the highest maternal and infant mortality rates, the highest rate of people with multiple chronic conditions, the highest obesity rates, and we have one of the highest suicide rates. For further reading in this area, you may want to look at a report issued by the Commonwealth Fund every few years, and it is titled Mirror, Mirror, Reflecting Poorly, Healthcare in the United States compared to other high-income countries. There are a few features that distinguish high-performing countries from the United States, from us. They provide universal coverage and remove cost barriers. They invest in primary care to make sure it is available in all communities. They remove costly administrative burdens that divert time and effort from improving the healthcare system. They invest in social services addressing the social determinants of health. Population health is a government responsibility. But there are many hopeful signs that we will begin to make the necessary changes to improve the health of our population, and I wish to remain optimistic. In line with government taking responsibility, New York City announced just last week that they received some troubling population health data. Specifically, life expectancy in the city dropped to 78 years of age in 2020 from 83 in 2019, the first decline in about a century. While some of this drop is attributable to COVID, mental health concerns, violent crime, chronic disease, and the overdose crisis all are causes of this life expectancy decline. So the city has just adopted a new agenda to address these concerns through an initiative they have entitled Healthy New York City. The city will implement a variety of outreach efforts devoted to cancer screenings, identifying persons with metabolic syndrome, high blood pressure, elevated blood sugar, and high cholesterol. They'll expand outreach services to substance abusers and those prone to suicide. The city's hope is that within the next 10 years, they can prevent 7,500 deaths. In announcing this program, the city's health commissioners said, "For too long, we have viewed health as an individual choice, but now the health of our population has to become a permanent fixture of how we govern." A further example of government taking responsibility for the health of its population is called the Partnership for Healthy Cities. Funded in part by Bloomberg Philanthropies, this initiative here and across the world supports mayors designing and implementing interventions to address non-communicable diseases such as heart disease, respiratory disease, and cancer. Efforts, however, require innovation. How do we do things differently? The Affordable Care Act established an innovation center to focus exclusively on the development of new models of care and thinking outside the box. Here are just a few examples. The mobile healthcare network emerging across the country employs community paramedics and community health workers to make regular medical visits to patients who are chronically ill, at high risk for medical emergencies, and lack access to primary care. For opioid abuse, the High Rockies Harm Reduction Program in Colorado works to reduce drug overdose death and the spread of infectious diseases by providing naloxone, prevention education, peer support, and linkage to other medical and social services. The patient-centered medical home is a new national model that enrolls patients in care that is delivered by a healthcare team, with the key ingredient being care coordination. This model addresses issues that promote and prolong life through effective chronic disease management and preventative care. And finally, and one of my favorites, the Money Follows the Person program is available currently in 36 states. This program permits Medicaid dollars to be spent flexibly. In other words, the dollars that would have gone to nursing home care can now be spent on supporting patients in the community. So healthcare is changing, and I hope I demonstrated some of the ways we are marching towards improving our population health metrics and promoting the common good. Here are some headlines from my reading just this past week. Governor Kathy Hochul signs bill to help Medicaid enrollees secure doula care. More health systems employ senior executives for population health. Researchers to examine best practices for overdose prevention centers. The NIH awards 7 local hospitals grants to improve COVID-19 testing for New York City public housing residents. NYU launches Health Dashboard to monitor population health across 900 US cities. As you can see, there is good news and many challenges ahead. So much for another talk on another day. Thank you. Okay, now I'm taking my papers off. You're welcome.
So, Ken, please don't leave. So we've started a practice now of the speaker being invited to answer questions that people may have, just 2 or 3 questions. We'd like to keep that going. And people who are on Zoom can also participate in this, but it's someone who's got their hand up at this point in time who'll be the first person. So, Robin, you want to stand up?
Sure, please. We got to give him a mic. We want to make sure we hear you. Remember, I have hearing aids.
It was very inspiring to hear how many of the major medical groups have it's very reassuring to hear. Okay. How's this? Better? Too loud? Testing, 1, 2, 3, 4. All right. Yeah, it's always on. Yeah, my ears. Anyway, it's very heartwarming to hear how many of these large medical organizations are adopting various programs, one for food, one for housing, one for care. What is your opinion about the possibility of such umbrella, such services being brought into as an umbrella for all patients from all medical practices to get all of those wonderful benefits, which really would make life better for many people.
Sure, it's a great question. I would say to that we're on a journey. We're in a different place now than we were 5 years ago. 5 years ago, we didn't talk about the social determinants of health. It was only social determinants of health is a long idea. It became titled and famous in a book in the early 2000s. And so healthcare systems are beginning to make that change. Would I like to see it more embedded across a larger universe? Absolutely. I just hearken back to feeling that we're making some progress and that hopefully we'll eventually get there. You can hear when I talked about some of the ways other healthcare systems or other healthcare countries orchestrate their healthcare, they're much more ahead of us. It's embedded. Susan and I recently took a trip to the British Isles, and in every community we went to in the British Isles, just walking through the streets, we could see different types of social services being offered as we walked around the different towns. So I want to get there, and I hope we will get there in my lifetime. Oh, okay, Wayne.
Hi, Ken. Thank you very much. That was wonderful. I think that you are a glass half full person, like I am. So I want to ask the other side of the glass, what are some of the major things that are not being addressed, that need to be addressed to continue to improve?
Well, you know, again, that's a big question with lots of different ways to answer it. We still don't have universal access for everybody, and I think that's a problem. That's a big problem about why our population health metrics are not what they should be. You know, it's a big debate in our country about universal health care, but if we had universal health care, we would immediately have more access. And there are many rate-limiting factors to people going for care. I said a lot of words in my talk, but I'll give you one very concrete example. So I happen to be on Medicare now, but when I had a commercial plan, I had a card in my wallet, and if you turned the card over, it said, if you want to go to the emergency room, it's going to cost you $250. So, you know, before I go to the emergency room and spend $250, that's a lot of money, I think about it. And so that's a disincentive. And that's another thing that we need to change in terms of making care more affordable. So we have lots of strides to make. What I see in some of these models that I like is that we're really starting to begin to focus on care coordination. Because one of the things that has gone wrong in our health care system, and continues to go wrong for some degree, is that many people fall through the cracks. Care coordination is an effort to make sure that people don't fall through the cracks. But do we need more of that? Yes, we absolutely need more of that.
Hi, I'm Ginger. Can you hear me? No? Hello? Okay. Whoa. I think that there is some progress has taken us backward. Some progress has taken us backwards. And what I'm talking about in particular is something like Northwell. If you call a doctor who participates with Northwell, you are on the phone for about 10 minutes just waiting to speak to anybody. And it's almost like talking to an automaton, because they have a recorded voice that says the same thing for every Northwell participant. And it's a huge conglomerate. So,
Ginger, make it a question.
Oh, it's a question. So,
What's the problem?
I think that we need to do something about that, because that's not progress.
Right. I mean, my comment back to that would be one of the business, I talked about market power, but one of the One of the other business concept of health systems is called a competitive advantage. Why should you do business with me instead of doing business with her, right? What do I offer you that's better than she offers you? And the answer to that is that some health systems are better at doing that customer service than others. I can think of a few examples. So, you know, I'm not encouraging you to change healthcare systems if you have providers that you're doing well with and your care is good, but we try to look for healthcare systems that are a little bit more friendly in their customer service. Not only that, but also what's changing is commercial payers are requiring healthcare systems and providers to do certain things. For instance, in managed care contracts, they now have a caveat in the contract that says you've got 4 rings to answer the phone, right? That's actually written into many contracts right now. So there's lots of wrinkles and lots of things that are not done well, and there are lots of negative experiences out there, but again, hopefully we're getting better. Sal.
Yes, good morning. That was a great presentation. Thank you. I just wanted to get your observation on the proliferation of urgent care centers and how that's changed healthcare delivery for us.
Urgent care centers?
Yes.
What I worry about with urgent care centers, I think, is what everybody worries about with urgent care centers, which is continuity of care, right? I never encourage people. I have used urgent care centers myself, but I don't encourage people to use urgent care centers as their primary care provider. You really want to have a relationship with somebody who knows you, who knows your medical history, who can give you advice on everything from vaccinations to screening tests to all of the things that you need for care. So do they have a role? They absolutely have a role, but I get a little concerned about that boundary between primary care and urgent care. Okay.
But are you available after?
Yeah, sure.
Okay, I know lots of people have questions, but we're going to save that till the end of the program when Ken is happy to stay and have a circle discussion.